Aspiration and the Pulmonary Biome, a clinical framework for dysphagia management.
So when discussing our friend bolus, we have B first, and that's for bolus variables. We need to be cognizant of what is aspirated, specifically the chemical composition as well as the density. With regards to chemical composition, the lower pH we have, the increased likelihood of a pulmonary event such as a pneumonia or pneumonitis. If we have something highly acidic like gastric contents, orange juice, tomato juice, that's when we can have a pneumonitis occur. Many speech pathologists will implement a water protocol. Water has a near neutral pH, and as Dr. Palmer discussed, the specialized aquaporin cells will help to remove that water, but in large part because of the pH as well. That's something why we don't have adverse events. We also must think about the density of the aspiration. We know from Dr. Langmore's seminal work that aspiration of solids does increase the likelihood of a dysphagia-related adverse pulmonary event, but we can also have, a lower airway obstruction from that as well. Some new data coming out of UC Davis showing that the thicker the liquid, the increased damage to the lung as well as compared to the near neutral chemical composition of the water protocol. But we also know from the protocol 201 work that the thicker the liquid, mildly thick liquids now, and then moderately thick liquids, greater increase of pneumonia for those as well. And I think in part it's because the lungs can't clear it out, and it's just sticky and gooey, harder if the cough isn't robust, and the mucociliary clearance can't clear it as well. The other thing we need to look at is how much aspiration are we having and how often. This fits very, very nicely into the immigration elimination framework. In the event that immigration overcomes elimination and it's chronic, that's when we can see increased odds of dysphagia-related adverse events.
So in our bolus framework, O stands for oral health and oral care routines. So the oral cavity is rich with microbiomes that contain colonized bacteria. In other words, bacteria that exists in specific locations. So we have distinct bacterial habitats in our teeth, tongues, cheek, palate, and gingival sulcus. And these bacteria can be transferred to the lungs when aspiration occurs. When you have low saliva production, then that delays the clearance of food from the oral cavity. It also reduces bolus cohesion and increases the risk that the bolus will fracture and that fractured material will stick to the dried oropharyngeal tissues. So good oral care routines can help overcome poor oral health. And good oral care routines would include things like brushing of the oral surfaces, rinsing those regions, and all of these things are to reduce the oropharyngeal bacterial load so that when aspiration occurs, the bacterial load is limited.
Next, we have for consideration mobility, or L, lifestyle and level of activity. Let's talk about level of activity first, specifically mobility. Although we weren't able to locate any specific research looking at level of mobility and dysphagia-related adverse events, Dr. Langmore's 98 study did, and 2002 a little bit touch on this, of patients that were bedbound are more likely to have a dysphagia-related adverse events. Our speculation is that because pulmonary clearance and pulmonary health likely isn't as good, we know this from the physical therapy literature, the patients receiving mechanical ventilation or ECMO as well. Those that are mobile do have better outcomes in terms of mechanical ventilation weaning and ECMO weaning as well. So we can speculate there that increased mobility, increased pulmonary clearance in the non-pulmonary diseased patient. At level of independence, we know that individuals that are dependent for oral care, dependent for feeding, we can run into some trouble one of two ways. Way number one, if you're dependent on others for feeding and careful hand feeding isn't implemented, there can be overly large boluses, too fast of pacing. If one is dependent on others for oral care, unfortunately, at times their oral health and oral hygiene may be overlooked, and there may be an increase in aberrant flora in the oral cavity as a result. Or they may have an oral care routine that isn't as adequate as it should be.
Okay, so as we continue discussing our bolus framework to help us identify risks for patients who aspirate, we are up to U, and U is for unintended or iatrogenic influences. Tubes, PEG tubes, nasogastric tubes that pass through the nasal and pharyngeal cavities contain colonized bacteria. These high levels of bacteria may be transferred to the lungs through aspiration. When microaspiration occurs, greater levels of bacteria will be transported to the lungs, essentially increasing the risk of an adverse event. Further, the presence of a feeding tube is positively linked to aspiration of gastric contents, thereby also increasing the risk of a pneumonitis. Mechanical ventilation. While the benefits of mechanical ventilation are clear, the delicate balance of the lungs microbiome is challenged. Use of mechanical ventilation can damage healthy lungs and result in increased lung edema. So remember, edema, we're talking about liquid in the lungs. In the presence of lung edema, where now I need more elimination, the efficiency of the mucociliary escalator is actually reduced. Further, patients who receive mechanical ventilation are sometimes placed in a supine or prone position, particularly now with these COVID patients. And both of these positions are shown to increase immigration and reduce elimination, further increasing the risk of an adverse event for patients who aspirate. Next, we have risk from another physiologic system. So here we are asking that when we treat a patient for dysphagia, that we don't shift the risk from the oropharyngeal cavity and the respiratory system to another physiologic system. So for example, if you have a patient who has aspiration on thin liquids only, and you say, okay, I want you to drink only thickened liquids from now on, and the patient says, okay, but they hate the thickened liquids and they decide not to drink anything. And so now what I've done is I've transferred the risk from the respiratory system to the kidney system or the renal system. So we want to be careful that we don't shift risk from one system to another. Although not on this slide, I thought I should also mention high flow nasal cannula or oxygen from high flow. And there's a lot of increased use of high flow nasal cannula over the last 2-3 years. And the data out there on high flow nasal cannula is a bit unclear, but I think the general thought is that the presence of high flow nasal cannula increases the vulnerability to dysphagia. There's very limited data. Most of the adult data was done with healthy folks. And they did show that high flow nasal cannula changes the timing and extent of laryngeal vestibule closure and duration of apnea. But these were all done in healthy adults. And those changes in timing did not result in any change to their penetration aspiration scores. So in healthy adults, they seemed to, even though there were some changes in physiology, it didn't seem to increase their risk. In pediatrics, the data lean more strongly towards caution. Most of the available studies in pediatrics are inadequate to answer the question on if it's safe to feed somebody who's getting high flow nasal cannula, because most of them don't include imaging, so we don't really know about their safety. The few studies that did include imaging show an exacerbation of swallow deficits with high flow nasal cannula.
So the last part of our bolus framework goes very nicely with this photo. So we have system health. So in this photo, if you can visualize, all of the fence posts in this photo have the common goal of creating a fence for this nice farmer gentleman, and it influences the immigration and elimination cycle. So these fence posts are there so we don't have critters such as coyotes and bears immigrating and eliminating the patient or the gentleman's livestock there. If we have all of the systems health, the general health, all these fence posts are down, then it wipes out the elimination or immigration system. But if we have a few of the fence posts down, maybe not so big as of a detriment. So let's talk about this a little more. The first and the biggest one is general health. And as we talk about these bullet points, I want you to think about two things. Are these factors modifiable or are they non-modifiable? Is my patient deconditioned or frail? Is this something acute or is it chronic? If it's chronic, we're going to see likely decrease in the immune system, decrease in BMI, decrease in ability to fight off infection, increase in ability for adverse events. Cognition, do we have an acute cognitive deficit, such as from a urinary tract infection or electrolyte imbalance? Is this something that family members or other staff can help compensate for? Or is this something that's more long-term where they're going to be dependent on others for activities of daily living and feeding, which increases the likelihood of adverse events? Are there various medical conditions, such as acute pulmonary conditions, such as acute respiratory failure, ARDS? Is there chronic pulmonary disease? Is there chronic chemical usage that's going to impact the mucociliary escalator? Can the patient cease the tobacco smoking, which we should see return into ciliary action? Is there any upper esophageal issues that are going to increase the likelihood of retrograde aspiration? Are those things that we can work with our GI colleagues to get under control? Cough strength, think again, modifiable, non-modifiable. Is this something that I can strengthen? Is this something that I cannot? Is this a chronic or acute dysphagia? Immune function, is the patient on immunosuppression therapy? Are there acute or chronic changes to the immune system where we're not going to have that second line of defense or the reactive defense system?